Hey, Kristina, welcome to the Empower Nutrition Podcast. How are you?
I'm good. Thank you for having me.
Oh my gosh, thank you for coming on. Most of our listeners are women, and omega-3 is basically one of the only most important things to talk about. So you're just like a perfect guest. So thank you so much.
Oh, this is great. I've been in the omega-3 world beyond the women health side, but once I found like pregnancy and breastfeeding, I was like, that is so much more important to me than everything else. So it's been really fun.
Yeah, well, that's a perfect lead into what I wanted to ask you. If people don't know, Dr. Harris that we had in the podcast already on omega-3s is your dad, and we talked a lot
Mhm.
about omega-3s there. And obviously, you grew up knowing about omega-3s. Then you went off into the world and did your PhD and worked quite some time in other realms of nutrition. And tell me about like
Mhm.
what brought you back into the omega-3 world.
Yeah, so I went to Penn State for my graduate work in nutrition. I went to Augustana College here in Sioux Falls, actually. And I was a biology undergrad, and typically that would be like a pre-med. And I was like, I don't want to be a doctor. Like, I don't want to be that kind of doctor. I don't want to have people's lives in my hands, and I make one little mistake and it's done. So that pushed me towards kind of research. And my dad was in nutrition, so I was like, it's kind of just applied biochemistry. So that seems
Yeah.
interesting. So I got it to went to Penn State, and I really liked it. Nutrition, just once you get past kind of the basic classes and you get into
Mhm.
the nitty gritty biochem, it's super fascinating
Yeah.
and complicated. And so I did that, and I was doing human clinical feeding trials, actually focused on whole grains. My mentor was Penny Chris Atherton, and she's been in the cardiovascular disease nutrition world forever. She just retired. So I was in the clinical realm, and then I had to take so many nutrition classes to just get caught up to the graduate level. So I actually ended up doing my registered dietitian training at the same time as my PhD. And so that kind of got me into being interested in the behavioral nutrition side.
Yeah.
So right after graduating, I went to the University of Colorado in Denver, and I worked there for about a year in kind of a worksite wellness type of place. But life is weird. And so my mentor that I was really excited to work with, he had a heart transplant like the week I got there. So he
Oh,
wasn't available to be my mentor there. But as I just kind of was able to busy myself and meet with different types of different potential mentors, different areas. And I just realized this area is so important. It's like
yeah.
applied nutrition, but has so many more variables, and it's just so much bigger. I just get like stuck and overwhelmed. So I decided to go back to kind of more biochem nutrition. And then my dad had been building Omega Quant for a few years, kind of on the side. He was working at a hospital here in town. And it was kind of getting bigger, and it became a real option for me to be able to work um, with him at Omega Quant, mostly focused on research, mostly focused on working with researchers to do testing with them, as well as using my registered dietitian credentials to really start doing some translation. And and then I got to also help run a small business, which has been quite the education as
Yeah,
well.
totally. I
Yeah.
feel that.
So, things just, you don't really know where it's going, where life is going.
Yeah. Yeah, and I mean, little backstory of my understanding is that you actually were a big part of adding additional panels specific to prenatal health to Omega Quant. And so that probably was kind of a risk, maybe, of
Mhm.
is it going to pay off to add these panels? And maybe tell me about why you felt, maybe tell me about these specific, like why you thought these
Yeah.
panels needed to be added.
Yeah. So, you know, there's always kind of this like high minded thing, like, oh, yes, we have to have this panel. But really, it was like, we know we can measure omega-3s in blood on a filter paper very well. We can stabilize the fatty acids. We have this technology. What else could we do? And then the first thing was, well, breast milk, because it's easy to collect. and DHA as a known important aspect of breast milk. So I guess just to back up, DHA is docosahexaenoic acid. It's one of the long chain omega-3s that are in fish in our diets. They're also really critical in pregnancy, breastfeeding, and the development of the brain. The brain and eye are just very rich in DHA, and so just structurally, we need it. And our body makes some of it. Actually, estrogen helps women make a little bit more of it than normal, which is to me just like pointing to its importance in pregnancy and lactation.
Yeah.
So DHA was always kind of our focus. The omega-3 index is kind of our larger, more global omega-3 status marker. That includes EPA, which is another long chain omega-3, both really important, both always really found together in nature. So with the general omega-3 index, we have both of those together. For the pregnancy stuff, almost all the research has been on DHA because of that structural component. It's really important for brain development. So we decided to just do a marker that's just DHA because that's going to respond to DHA, and a lot of the trials use only DHA, although many of them use a mixed fish oil as well. So we decided to just kind of see what we could see in the literature around breast milk DHA. And as I was doing that, I was finding a lot of really interesting stuff, but it's very hard to find studies where they didn't also supplement during pregnancy, where they just started at like lactation, and then the pregnancy levels in the mom's blood really affect the breast milk levels. It makes a lot of sense.
Right.
Breast milk is like taking the first DHA. It's always like the primary source where your DHA is going to go. But in pregnancy, like I just kept finding all of these studies that were happening in pregnancy. And so after we did the DHA, the mother's milk DHA, the breast milk DHA, we're like, there's way too much in pregnancy. We have to look at what a DHA level in pregnancy would be. And so that's kind of where both of those came from.
Okay. Yeah. So it sounds like in the research, most of when we see outcomes related to omega-3s and for fetal development, it seems to be clear that like the DHA is maybe more impactful than the total omega-3 level or the EPA level. And so that's why these tests single out the DHA level. You can look at it from blood when you're pregnant, or you can look at it in breast milk when you're breastfeeding. Is that right?
Yeah, that's right. And I would say like it's never just about one thing in nutrition, and we do think that there are several other omega-3s that are playing roles. The DHA is the clearest signal. It moves it, and it's usually directly related to what is being supplemented. And so we wanted to make it clearer. It was also like partially just how do we communicate this in the clearest way that has the most connection to the research. The research usually they only report DHA in the milk or blood. So we needed to have research backing for the targets that we set. So that's another reason. But it isn't true that it's the only important thing, of course. It's just a good signal. And usually when you have higher DHA, your EPA increases too. And so it's doing something. There's always more to know that we don't know. But what we do see some pretty good correlations with higher DHA levels and pregnancy outcomes and things like that.
Yeah, maybe tell me some of those specific outcomes that are significant with that of like what's seen in the literature.
Yeah, so where we got really excited was the preterm birth literature in 2018 or 19. I'm now forgetting which one. A group in Australia headed up by Maria McCrides. Her and Bob Gibson have been doing huge studies with omega-3 supplementation in pregnancy for decades. It's their careers work. And they their group did something called a Cochrane review, which is a very standardized way to do a meta-analysis. So bringing together every study where a pregnant woman has been given fish oil or DHA, and they tried to pool everything together and look at these outcomes. And Middleton was the first author, Dr. Middleton. And so they found that when they pooled a lot of studies together, that the preterm birth rates for women who were on the omega-3 arm compared to the placebo were about 10% lower than the placebo arm. So that's good. But the early preterm birth rates, so preterm is defined as before 37 weeks, early preterm, they define as before 34 weeks, although there are other terms, but I'm talking about before 34 weeks gestation. So women who had fish oil, they had a 42% reduced risk in this analysis of having early preterm birth if they were given omega-3 compared to the placebo. That's a huge drop.
Absolutely.
And
yeah,
we start, as we've looked into this more, there is nothing available to prevent preterm birth specifically. There's no like drug. There was a drug that was on the market and it was recently taken off. I can't remember the name of it, but it's no longer available. So it was basically kind of a steroid. And the options right now, if you are at risk for preterm birth or early preterm birth, which you don't even really know that, especially if it's your first baby, there's really not much there.
Yeah.
And it's kind of vague. It's like being very, very old or very young, being kind of the extremes of age and weight. And if there's smoking and drug use, it's kind of bigger things than a specific biomarker. And the other risk factors are, have you had a preterm birth before? It's your first, you don't know. And so there's really a need here to give doctors and pregnant women, like, it's a huge deal to know if someone may be at risk for preterm birth.
Yeah.
So the omega-3 story came in and found like this intervention. It's not just like we're not to the part where we're showing that levels of omega-3s can predict preterm birth, but we are showing that if you give omega-3s during pregnancy, that you can reduce risk. And it's during pregnancy. Most of these studies don't actually start supplementing till mid-pregnancy. They recruit people don't know they're pregnant. It's so hard to study pregnancy.
I know.
So hard.
Yeah.
So
by the time you can get going, you've missed half of it.
Yeah. So it's really second half of pregnancy. It's not like folic acid where it's like once you know you're pregnant, you weren't taking whatever, like you already missed the boat, even though we have fortification, which is why we have fortification.
Yeah.
The omega-3s, it's great to have it on board prior, but you can use it even 20 weeks gestation after that, doing a dose. So that to me was also like, it's just kind of a relief as a pregnant person, just to know that there's something that might work.
Yeah. What kind of dosing? Was it some really high dosing or just kind of the typical like 1,000 milligram dosing or?
So they looked at, in the meta-analysis, they separated it by dose, low, medium, high. They didn't see any statistically significant differences. There was kind of a trend. The authors kind of felt like maybe 500 plus would be milligrams of DHA per day would be good. But after this meta-analysis came out, there were two very large studies going on. One was by the McCrides group in Australia, and one was by Susan Carlson at the University of Kansas Medical Center. And so we had this big finding from all the previous research, and these other two big studies were designed to test that question specifically on early preterm birth rates and omega-3s. One of them was using 1,000 milligrams of DHA dose, and one was using 800 milligrams of DHA plus 100 of EPA. So it's like pretty close.
Yeah.
So the Australian group did not see an overall effect of omega-3 supplementation on early preterm birth rates. And that one was like 5,000 women. It was huge. What they did, though, a couple of things kind of affect this, is they included pretty much any birth. So they included people having multiples. And it's pretty well established, especially now, that if you're having twins, the DHA or the omega-3s don't elongate pregnancy. They don't reduce risk for early preterm birth like they do for singletons. Not that it's not good to have omega-3s for other reasons,
Yeah.
but that would not be an expectation in that setting. So when they just looked at the singleton births, they did see a significant effect of the omega-3s. And they also found, which is the other group found, this is the people who benefited the most from the being on the omega-3 arm of the study were women who started out with low omega-3 blood levels. So low DHA, low EPA DHA blood levels at the beginning of the study, which makes a lot of sense. It's like it's sort of a deficiency situation. And so when they did that sub-analysis, they did find that that was a significant effect. And then in the Kansas City study, they were giving 1,000 milligrams of DHA versus 200. 200 milligrams is kind of that like standard DHA prenatal dose right now. And they found, so they're running their study with about 1,100 women, so still very big. And they found a significant overall effect. They weren't taking it in women who were having multiples. So it was just singleton births. So they found the omega-3 group, the higher dose omega-3, they're both getting something. The higher dose omega-3 group had lower early preterm birth rates. So that was great. And then they did an extra analysis and found that almost the entire effect is happening in women who start off with lower DHA blood levels. Okay. So it's like this threshold effect to me where you're kind of, if you're in this kind of deficiency state, if you have low levels in your blood as a pregnant person, supplementation can actually help reduce your risk for preterm birth. It can elongate pregnancy. If you have good status, if you have a decent amount of DHA, and we're not talking like the 8% omega-3 index, we're talking like 5% DHA. Okay. It's kind of it's more of a threshold. It's more of a not deficient, a sufficient status, not an optimal status per se. That those folks, they don't really benefit from a higher dose. 200 milligrams is fine. Like they already have enough stores, their status, their diet is probably already bringing in enough. And there are other things that can lower DHA, like smoking cigarettes and I think prenatal alcohol exposure, those can kind of lower DHA. So having that good status doesn't mean everybody needs to be on a really high dose of DHA for this effect. And there's the flip side of sometimes it makes you go later into pregnancy than people want to because it can be so effective at delaying the onset of birth is really what it's doing. It's just you're not going into labor as quickly. And so those are like the big studies that really solidified for us that this is a really pretty critical marker to have something that could not only it was predicting, like the omega-3 level was predicting who was more at risk or having preterm birth, but also you have an intervention that's very safe, very affordable, very accessible. It's kind of, for us, it's a no-brainer for it to become like, how do we make this part of practice? This could be like they could talk about this like they talk about prenatal vitamins. But to have that extra test in there, to have that higher dose, it does take, you probably want some kind of prescription or something. You're going to have to do more than just like a standard low dose omega-3. So having that protocol is something that that's a whole different world to try and figure out how to break into clinical protocols. But that's the translational step. We think this would be really impactful and targeted. It's really, we're not just like, everybody needs to supplement so much. It's very much based on your personal status.
And would you say that having that similar type of status is the same for other outcomes related to omega-3 in pregnancy, and maybe talk about like what those other outcomes that are researched are aside from preterm birth and What
Yeah.
kind of omega-3 status are we talking about with those?
Yeah. So that's interesting is with the birth literature, this is a pattern that there is a status, there's kind of a deficiency threshold. And then after that, so if we're just talking about DHA levels, 0.5% has actually shown up in some of the other outcomes, as that's kind of a threshold. If you're below 5% and you get a high dose supplementation during pregnancy, you have better outcomes. But if you start out above 5%, you can be on either dose and you're having better outcomes.
Is
So
it 5% is your omega-3 index, or 5% is your actual DHA percent?
actual DHA percent, which is about a
Yeah.
6% omega-3 index.
Okay.
So
I see.
it's a little more than our 4%.
Yeah.
So another study that found what's the best is when studies actually measured the blood levels at the beginning of the study and publish their data based on that. That doesn't happen. It's happening more, but that's a missing piece. So there was a big study in Denmark. I think it was Denmark. It's called the COPSAC study. They gave about 2 grams of fish oil, which is about 1,000 milligrams of DHA, to pregnant women. And they were looking at asthma and wheeze in their offspring. They're following these kids as long as they can, but I think they're at least at 6 years of age follow-up. And they found, I think at 3 years of age, that the women who with low status, less than 4 or 5%, they got the omega-3 dose, they had a significant reduction in their offspring having persistent wheeze or asthma.
Okay.
The group that had low status and got the placebo had the highest rates of that. The women who came in with blood levels that were above 5%, it didn't matter if they were on placebo or the treatment. So it's again, like everything's happening at the lowest levels. So and I'm trying to think if there's one more that I always point to. There's been another one that was just looking at fish intake. It was Dr. Olson. He's been also a giant in this field. But they were looking at women in China in different areas where some would eat fish a lot and some wouldn't. So they kind of use that as a proxy for DHA status, and found that the women who didn't eat a lot of fish were the ones who benefited from the supplementation, and everyone else really didn't, as it pertained to preterm birth. The big research, this area actually probably came about mostly to do the brain development and eye development, because it's so rich and it's so omega-3 is just kind of shockingly rich. And those studies, there have been some good findings and also some very mixed findings. And I think that's for partially this threshold reason of, if you aren't testing who you're bringing in and you're not analyzing the data based on that, then you might have women who don't need that extra supplementation. Or there's another big issue around actually measuring like infant or young childhood cognition.
It's hard.
It's really hard.
Yeah.
And they're developing at different rates anyway. So what's good and what's bad? There's a little stronger data on just looking at epidemiologically, like fish intake and IQ. Those are kind of bigger studies. They're not randomized controlled trials. So those areas, I think there's more benefit, there's more coming out on that, like the wheeze and asthma side, and also starting some of the neurodivergence and seeing how these fatty acids are playing into those types of developments. But all of that is so much less clear than preterm birth. And part of it is just because the outcome of preterm birth is so much more obvious. It's like, it's a day.
Exactly. You don't have to wait years to be able to measure that. Meanwhile, 1,000 things have happened. If you want to measure like a performance of like a second grader, it's like the whole world has been impacting that child for 7 years. Who knows if it was omega-3 or 1,000 other things. Yeah.
I know. So I have a hard time. I do think it's very beneficial for just general development in that way. But the data on that to me is not, I'm not like, I'm more, I feel a lot more convinced by the preterm birth stuff, which would also go along with all the other developmental benefits is if you stay in the womb longer, you
Right.
have more time to develop in a better
Yeah.
place. So you want to get to, it's all works together a
That's
little
a good
bit.
point. Yeah. Yeah. I mean, it makes me think about, God, nutritional research is just so hard and for almost
It's the
everything.
hardest.
But if something is critical while you're in utero,
Mhm.
and then it's, people can refer back to the interview I did with your dad or any of his other interviews. It's obviously critical midlife and end of life for
Mhm.
health. Then, like, chances are it's probably also critical when you're a child, like a child and
Mhm.
an infant. So,
Yeah,
yeah,
I know.
it's just kind of the oil that your car runs on. So,
It is. And it's interesting because like omega-3s are more like other micronutrients. Even though they're fats, they're just their
yeah,
specific structures are what makes them useful in certain
mhm,
ways. They're like proteins, I guess, also in that way.
yeah,
And so they live in the membrane, they create the membrane with all the other types of fats. And then when, I mean, it's mostly around the inflammation pathways where they're
yeah,
impacting.
yeah,
Um, and if there's a signal that there's inflammation, then they're getting pulled out of the membrane and
mhm,
they're being changed by enzymes. And then they're becoming these molecules that last for minutes. And they may have a really important role in the inflammatory process or healing it. And not having that primary material in the membrane is kind of messes up the rest of the chain. When so much is affected by inflammation, it's just that's where it just kind of balloons in its importance. But then also the structure, just like the basic structure of our tissues, needs the needs the primary sources. And so that's why
mhm,
I also think it's so interesting that there are several ways in pregnancy where the body is optimizing for DHA and arachidonic acid actually, which is an
mhm,
omega-6, to be transported to the fetus. The placenta will pull DHA and arachidonic acid over,
mhm,
and the baby's cord blood is often higher than the mom's levels. And if the placenta is not functioning quite right, then that can really affect how much DHA and arachidonic the baby's getting. Um, and like I said, estrogen actually increases our ability to make DHA because we
amazing.
can, which is like so cool.
Yeah,
It's really, yeah. And so there are all of these signals of like, this is a nutrient of importance. It's specific. It doesn't get used up for energy. It's conserved by the body to be in membranes to be available for all of these
yeah.
different things.
Maybe tell me about who should be considering testing in terms of, so like we do omega-3 indexes all the time in clinic, and it's
Mhm,
super common for me to see people come in at 4 or 5%. That seems to
mhm,
be pretty much the norm if they haven't
mhm,
been supplementing. And so
mhm,
if we're aiming for at least 6% roughly
mhm.
before pregnancy, to me that would almost mean, okay, like every woman wants to figure this out. Should she get
Yeah.
it? But tell me, why should she think about getting the DHA specific test instead of the omega-3 index? And then tell me if she's kind of like really on the fence. What are
Mhm.
some things she should think about in terms of like what her diet looks like, if she's probably good or not?
Mhm. Yeah, I think that's a great question. I'm not super precious on is it the omega-3 index or the DHA because I know they're very highly correlated. So if you're used to doing omega-3 indexes, I would just use a 6% cutoff
Hmm.
in your mind, even though that's not what's on the report.
Yeah.
Um, and then if you have the prenatal DHA report, the 5% cutoff.
Mm.
The only risk to that is if someone is supplementing and they are taking like an EPA only or a very high EPA
Yeah.
product. That's the only reason I would be like concerned if they're that just is like if you're eating fish, you're getting the right amount of DHA in that.
Yeah.
So typically having 2 fish meals a week is equivalent to having 5% DHA on average. This is very individual though. If you're eating tilapia and shrimp every week, that's not
Yeah.
really a good source of DHA. So you're not going to have that. Not that that's a bad thing to eat. It's just not going to have a lot of DHA. So, salmon, trout, sardines, herring. I mean, it's kind of some stinky
Bivalves.
fish.
Yeah. Yeah.
But a lot of them there are ways to prepare it that are becoming a lot more palatable, and they're just, you can do, I mean, 2 or 3 servings a week out of 21 meals it's doable.
Yeah.
Tuna, people are very concerned about tuna, albacore white tuna for the mercury content. And so that one's only recommended to have once a week. And that, even like the mercury levels, you'd have to have, I think, 3.5 pounds of that kind of tuna per week to hit mercury levels. So it's not, yes, it has mercury, but it's a dose issue. And if you like tuna, you can continue to have tuna, I think.
I agree.
Go with once a week if that's what you're comfortable with. Salmon is kind of like
Do that.
easiest, best option. That's what I mostly have.
Mm-hmm.
But the whole conversation around fish and pregnancy is fraught. So that's actually where I really like the testing, because it gives you a clear picture of like what you're doing now. It's giving you this. Mm-hmm. We have data that if you bump your levels up even just a little bit, we could help it could elongate your pregnancy. So if you're don't want to eat fish, you can go get a supplement. You can do, if you're at below 5%, you should go for the higher dose supplements. Mm-hmm. A lot of them are at like 600 milligrams, I feel like, for prenatal. But 600, 1,000, you can just do a gram a day. I'm not as worried about it being 1,000 of DHA specifically, but if you're getting 1,000 EPA and DHA, that dose is usually giving you a really good dose of DHA. Yeah. And that's a pretty typical supplement you could find. So you can have a normal fish oil. It does not have to be a prenatal fish oil. They're all kind of the same. They're just slightly different ratios. So that doesn't matter as much, as long as it's not just super high EPA. And so if you test and you're low, I would recommend supplementing, especially if you're already pregnant. If you're preconception and you're like, I want to do this through diet, then you can start increasing your fish through diet. If you're pregnant, you want to get supplementing as soon as possible.
How about sorry to interrupt your flow, but you guys have this great calculator on your website that kind of says, okay, if your level is this and you want to get to that, here's how much you need every day. You just got me thinking about, like, if someone's pregnant, I could imagine that calculator not being validated, or would you still use it?
That is based on data from pregnant people,
is. Okay,
but
nice.
It is just a general guide, because I think one of the issues we run into is someone would be like, for the omega-3 index, I'm at 4% and I want to go to 8, so I'll start eating fish twice a week. It's like, that's not going to do it. No. You need like 2 grams. Yeah. And so we did a study. We got a good calculator going for that. For pregnancy, we have a lot less data. So it is a ballpark. It's always like at least 200. If you're low, if you're below the 5%, you want to be up towards the 800 or 1,000 milligrams a day. If you are above 5%, I would say even make sure you're getting at least 200 milligrams a day. You can still take the higher dose, but at least getting a little bit every day is still good. And if you are at 5%, you probably already have it in your diet. It's just making sure that you're doing it and you're continuing with your similar diet habits. And the problem is there's so many different options that mostly all work. So in between 200 and 1,000, take your pick, kind of. It's like, just find something you like, whatever you're used to, whatever you like, whatever you're able to stomach, whatever you can take is what you should take. Like, I just am not as worried about the ratio of EPA and DHA. It's all about the extremes are not great, but there's so much available in the middle of it. So that's kind of, it's a squishy answer. If I have your number, I know I need you to be at a high dose. And if I'm a doctor and I know a supplement that I like, then that would be great. Give them that
Sure.
guidance. But I just
Yeah.
can't personally be like, go for this supplement and this, because they just change all the time and there's too many
Oh,
to be.
totally. Yeah. No, I mean, then there's a ton of great options. So yeah.
You really
What
are.
about, yeah, tell me about, so like, let's say, okay, I'm pregnant. I want to avoid preterm birth. I get
Mhm,
my omega-3 index to 6% or my DHA to 5%.
mhm,
I deliver at 40 weeks. I'm breastfeeding. What things am I thinking that omega-3 will
mhm.
status will do for me now?
Yeah.
And how do I think about getting another blood test versus like the breast milk test?
Mhm. So as the mom increases blood levels of omega-3s, breast milk levels will be elevated, especially in the first 6 weeks after birth. So even if you kind of stopped supplementing right at birth, or you needed to stop supplementing because you were going too far, you're going like to 42 weeks, then you can, I mean, you can always start up again as soon as you're done, but you're going to have a higher store in your body. So the breast milk is a higher level. So DHA levels in breast milk move pretty closely to mom's status and diet.
Mm.
It's super interesting because we have a study that we collaborated on where the moms were just getting 200 milligrams a day in lactation. And like 100% of that DHA was going straight into breast milk and not affecting
Wow.
mom's status at all.
That's motherhood in a nutshell right there.
Right?
Just giving your whole everything to your
That's right.
kids to suck your life out of you. So
They get all the first round of all the nutrients, and mom's just
that's
hopefully maintaining. um,
oh.
ugh. So, but it doesn't really, DHA. So like fat levels in breast milk change throughout the day and throughout a feed and all like, and that, but when we look at the percent of DHA in the fat, that is pretty steady and correlated to what mom takes in.
Mm.
So if you're testing or something, we recommend trying to do the first feed of the day, but that's like, when does the day start? If you're up in the middle of the night, and then
Right.
maybe doing it in the middle of the feed, but it's very stable in that way because we're looking at a percentage. If we were looking
Mm.
at an absolute concentration, DHA levels would be low in the foremilk and high in the hind milk just because there's more fat in the hind milk. So
Okay.
that's a
Okay.
big,
Yeah. I was assuming you would just pump and you would mix up all the milk from the pump and just test that, but
yeah.
can you just like drip it onto
You
the
can just
thing and
drip
not
it.
pump?
You can pump it and
Okay.
then just mix it up and take a drip. It's
That's
pretty
so
robust.
cool. Because some moms don't even pump.
I know.
That's so
I
cool you
didn't
do.
really pump a lot because my child was with me and she
Jealous.
didn't take a bottle forever. So I was like,
Yeah.
I'm not going to pump for this.
I actually had one of those, the no
Yeah.
bottle baby. Like, what is that?
Oh, gosh. It was rough as it
Yeah.
went on. It was
He's
rough.
my sweetest one though. So I'm like, it paid
I
off with
know.
you.
I know. No, it's so worth it. And it was fine. Um, so the same kind of outcomes with breast milk. The brain is still growing quite a
Yeah.
bit. Like the first 2 years. That's that first 1,000 days from conception to 2 years. Brain growth is incredible in the first year of life. I mean, and you think about baby has to get out of your body with a pretty big brain, but it can't be fully developed because that no one would survive that. So it's the growth that happens is just huge. And this is where breast milk is a great source. Formula now typically has DHA and arachidonic acid. If it doesn't, you can use some drops.
Mhm.
They have like baby drops.
Okay.
As you introduce foods, you can always introduce fish when it's appropriate. And there's also like I use some drops just to put in milk and cereal or yogurt. There are lots of little ways, but breast milk and the mom having a good status, which the breast milk and the blood are usually pretty well correlated. So the breast milk is probably what I'd recommend if you're mostly breastfeeding. Testing breast milk, if you want to wait at least a month. So it's not transitional milk or colostrum.
Okay.
So it needs to be mature milk for it to make sense.
Yeah.
And if you're kind of low, so the percentages are totally different for this. So 0.3% of the milk fats being DHA is kind of a low, but it's a sufficient level again.
Okay.
But we see that women in the US typically are at like 0.2, 0.1, 0.5, 0.15 or 0.2%. We're trying to
It's
get
like
to
half.
0.3%.
Yeah.
It's very small. It's like
But
within 0.3 and
yeah.
1% is where we see the most of the variety in people who are eating fish in all
Yeah.
different kinds of the world, all different parts of the world. That's kind of the scale in milk. It's just totally different.
Yeah. But it sounds like you're saying like maybe the average American woman could be sitting at like half of the minimum, like frequently.
Yeah. And
Yeah.
and for that, 200 milligrams of DHA is typically enough to get you up to 3.3%. So it's that 200 is, I think it really is a pretty good number, 200 to 300 milligrams, to just cover the bases
200 to 300 milligrams of
of
DHA every
DHA.
day.
hmm
Yeah.
That's on average, usually gets blood levels to where they need to be. But we
Yeah.
do see good outcomes in women. Like women in Japan have a 1% DHA. There's some interesting studies in some different tribes where mom's levels are about 8% DHA and her breast milk is 1%. And they kind of
Yeah.
postulate that that is at that level, mom is not depleting her stores
Oh, wow.
for that level. She's actually, if she's able to maintain 8% and the breast milk's at 1%, then she's not depleting herself.
Hmm.
Below that, mom is probably depleting her own stores. Like there's some evidence that like as the pregnancies, as you have multiple pregnancies, you have lower and lower DHA levels.
Hmm. I wonder
So
if there's any research on that and depression. Like,
yeah,
you
there
know,
was one of the big studies by the McCrady's group was on postpartum depression specifically. It's a
mm,
little different if you're thinking about like long-term
yeah.
depression outcomes. Because the postpartum depression, there's some evidence on blood levels. The study they did with supplementation didn't affect postpartum depression significantly. But there was like Dr. Michael Crawford is one of the biggest omega-3 brain researchers. And he was like in the 70s, he was like looking at the brains of all these animals on the savannah, and like they didn't have access to fish, their brains were really small and all this stuff. So, but his postulation was like, if omega-3s become very low in the general population and for pregnant women, as that happens, brain issues will start showing up. And
Wow.
and so we're seeing a lot of different kinds of brain issues for a lot of different reasons, but that was one of his hypotheses, and it seems like it is contributing to it. It's not probably the only cause, but not having that good base of omega-3s during brain development can have long-term outcomes. But I don't want to freak anyone out with that. It's not like if you
Yeah,
do it,
I
then
know.
you're guaranteed for this. None of this is like that. It's all just different levels of kind of risk. And it's like you're maybe a little more likely or a little less likely
Yeah.
with a whole bunch of other variables in there. But it is
Yeah.
something that could potentially help if and it's very safe and it's a nutrient. So that's kind of, I
Yeah.
try and live on that line because I don't like the stress that nutrition advice can come along with. It's like, we're trying to help, but we just made
Yeah.
you feel terrible. So,
At the same time, though, I mean, I think it's so important to help women be well informed because there's so much
mhm,
confusion with, like, say, the plant-based diet movement
mhm,
around, like, okay, I'm just gonna only eat plants, and there's omega-3 in flaxseed oil, there's omega-3 in chia seeds, and so, like, if I think there's so much of that around that women can kind of be deceived into thinking that that's sufficient. And I in fact see that in clinic all the time of like, I'm sure my omega-3 status is good because I make sure to have some flax seeds every day. So it is
mm,
important to kind of get the truth into
yes.
the world that this humans were designed for omega-3 from
Yeah.
animals. Like, it doesn't increase your omega-3 levels. DHA is not coming from flax seeds.
Yeah. Yeah. No,
It's not.
it's so
So it's not the same thing.
the flaxseed, if you take a ton of it, you can raise your EPA levels just a little bit. And typically DHA levels don't move
Yeah.
with that. So that's a really important point. If someone is vegan or vegetarian, there's algal DHA now
Yeah.
made from the algae. So that, to me, if someone's not having fish,
Mm-hmm.
try to get them
Totally.
a great vegan alternative, because the fish eat it from the algae, so it just kind of skips it, skips the fish. And so hopefully that is a good source for individuals who are not replenishing, because they're going to have stores in their body unless they've not touched. I mean, they're going to have some amount of DHA in their body, but they will get depleted so fast. And that's where we start to see the outcomes happen, is when you're on the edge of deficiency. Your body your body is going to do everything it can to, it's robust. It has secondary systems for things, but if you push it to a point where you just aren't giving it that nutrient, it's going to finally have some outcomes where it's not what you want it to be.
Totally. I mean, I think often women are kind of walking in a situation where, like, without them realizing it, they're about to get drained of their omega-3s. The world is kind of giving them these weird messages that maybe just having flax seeds or chia seeds is going to work for it. Then they're hearing, which is true, you shouldn't be eating raw fish, but that can kind of get simplified, I think, into a message of like, well, just don't eat fish in general. Also mercury, so just don't eat fish. I see that a lot of like, well, I just stopped eating seafood as soon as I got pregnant. It's like, no. So I think it's just kind of the perfect storm, right at this beautiful moment when, like, you're building a new brain, you're building a new human, and like everything is forming. And so I think it's just such a blind spot. Yeah,
it is. And I just actually gave a TED talk on that exact like melding of worlds, where this research on DHA, fish-based nutrient, coming up against the years of the mercury story and the sushi issue, just so much confusion for women.
Yeah.
And a lot of it is like well-meaning. Like the mercury stuff was well-meaning. It was just blown way out of proportion.
Yeah.
Like the original studies were on people who ate pilot whale blubber for their traditional foods. And that is a very rare thing to eat. And it's a large fish, it's a large sea animal that has lived in the water forever. So they have really high mercury levels. And it's like, that's not what we're eating.
No.
It's different.
No.
So it's so important that clinicians like you have this, are able, that's again, where testing might be able to cut through the noise. And if a physician doesn't want to debate a person about their fish choices, because it's stressful.
Yeah.
The person, they're just trying to deal with all this information coming in. It's like, we can test you and then you can take a supplement and it's fine. That's
works. I love about your testing. It's so inexpensive. And so it's like, same. It's like, instead of us just trying to sit here and like theorize about what might be happening, let's just get you this little test. It's like less than $100. Yeah. It could change the course of like your health history. It could help with your prenatal development. In the case of pregnancy and breastfeeding, it's like such a no-brainer. And then you have some data to work off of. Yeah.
This is actually it's kind of surprising how strong this data is. In nutrition, it's just never that clear.
I know.
But it's been very exciting over the last like 5 years. These like big researchers, Susan Carlson and Maria McCrides, are currently like in implementation in the hospitals that they've done their studies in, where they're trying their darndest to get testing or at least questionnaires to the OBGYNs to identify women at low status or low intake and provide information to those women to say and support and be like, this is a good thing. So the next step of educating the clinicians is kind of where the big research is at.
I think a validated questionnaire would be really good.
Yeah. That's what they're doing in Kansas City right now. It's good, except there is something about having a blood marker that
Yeah.
makes it easier.
Oh,
Well,
yeah.
you don't have to have someone fill it out, number
Yeah.
one, because that's
The
tricky.
thing. Mhm.
And it's a little bit more of a yes, no. Like there is a high correlation, but it's not between blood levels and fish intake. But it's not 100%. And it also then depends on dietary intake data is always fraught with, you don't really remember.
Yeah.
I
There's
know
nothing
I'm
like a
supposed
blood level.
or they're like trying to answer the way they think they're
Of
supposed to.
course. Of course.
So it could
Yeah.
go either way,
Yeah.
which is very normal in human. It's not like,
Mhm.
oh, that's so bad. So that's where I just like, we already take blood for a bunch of stuff. Just add in fatty acid testing.
I really wish that it
Yeah.
would just be part of like a normal prenatal workup. That would be amazing.
That's kind of our
Someday.
next, like we've been working in kind of the at home testing space, and because it's very hard to get new tests into the rotation with
Yeah.
it's more of an insurance and lab and hospital store like
Yeah.
thing than, and we aren't really in that world. But that's where I really feel like it needs to be in our bigger systems to have a big effect.
Mhm.
Because we do see that DHA levels track with socioeconomic status pretty
Yeah, the
clearly.
person who's working with us that's gonna pay out of pocket for the
Mhm.
test is probably the least likely person that's low.
Correct.
So, what about
That
everybody
is
else?
exactly right. So if we
Yeah.
aren't able to put this where it needs to be, what do we expect to happen? It's going to
Mhm.
help status for women, and I'm happy about that. But where the data shows the real impact is going to be women of lower socioeconomic status, and just getting them the information they need and hopefully the right like a product to them
Yeah.
early on in pregnancy could really that's where it's most likely to have a pretty big effect on the preterm birth rates. So yeah,
Awesome.
you're exactly
Okay.
right.
So if you're thinking about getting pregnant or if you are pregnant, if you're breastfeeding, it sounds like, correct me on any of this, get
Mhm,
2 servings a week of fatty fish,
mhm,
maybe max of 1 on tuna, but otherwise cooked salmon, and then those
mhm.
little oily, yucky fish.
Yeah.
Figure out if you can find a way you
Yeah.
like to eat anchovies or sardines.
Mhm.
And then consider getting your blood levels tested either pre-pregnancy, probably just go with the omega-3 index. During pregnancy, you could do that, or the prenatal DHA.
Mhm.
And then it sounds like you want to be at least 1 month postpartum breastfeeding to get the mother's milk test and those
Yeah.
needle. Then you can just drip the milk or pump the milk
Yeah. Yes.
and go from
And
there.
I would say for the blood levels, those usually take 2 or 3 months to change.
Yeah.
So if you kind of find out at like the 12-week mark, if you're the early first
Hmm.
trimester, early second trimester, you could take a first test. And then you could take another one at the beginning of the third to
Hmm.
make sure if you're a clinician, you can do it to make sure they have been taking anything. If you're yourself, you can just do it to make sure you're getting a good enough dose.
Hmm.
For the breast milk, that changes really fast. So if you're trying to bump levels up, you could test initially and then retest in 2 weeks or a month
Cool.
easily. So
Yeah.
it's just a little different timelines.
I love the repeat test after a couple of months just to see if this
Yeah.
product is moving the needle, because there are
Yes.
quite a bit around like genetics and as well, and
Mhm.
like you said, other inflammatory factors that play a role in like how quickly the status changes.
Yeah, yeah. I mean, everyone is different. We see these averages, but they are averages. So if
Yeah.
something's weird with your numbers, typically we can figure it out. There can be big absorption issues if you don't
Yeah.
take the supplement with food, especially with
Mhm.
fatty food. Um,
Or
that
any lots of other reasons for fat malabsorption. Yeah.
so
Yeah.
like you could be being very good and taking your supplement
Mhm.
and you're just not absorbing it. We have
Totally.
seen that. Like you can take 2,000 milligrams a day and your blood levels don't change because of an absorption issue.
Yeah.
Usually changing the supplement or taking it with food can usually help that,
Yeah.
or dealing with the fat malabsorption issue as well.
Absolutely.
Um,
Yay.
so yeah, lots of fun. Lots
Oh
of
my
things
gosh, so
that
good.
mess up nutrition studies.
Yeah, Kristina, thank you so much. And
Yeah.
I know our audience is going to be so grateful to hear all this. And maybe real quickly, I know you have to jump off, but where can people go if they want to learn more about your testing?
Omegaquant.com is where you can order your own testing if you're a clinician. We also have a healthcare provider ways to work with you, lots of different ways to work with healthcare providers. And we're on all the socials. And I just did my TED Talk, which I think is called the Revisiting the Ban on Fish and Pregnancy or something like that. That just came out like this last week. So you can just search
Congrats.
my name and TEDx, and it should, and fish or something, and it should pop up. So that,
Congrats on
there we go.
that. That's amazing.
Yeah, it was fun.
Well, thank you, Kristina. This has been awesome. We'll make sure to link that in the show notes and definitely be available for questions. And just thank you so much for coming on the show.
Thank you so much. This is
All right.
fun.
Same. Take care.
Bye.